I would like to welcome Michael Muiti from JPIEGO, JPIEGO, yeah, to come and talk about excessive bleeding after birth, introduction of life-saving HPTs to the public sector. Okay, don't beat me up.
Yeah, so thank you very much, and good morning. Yeah, so my name is Michael Mwiti. I work with JHPIEGO as a senior program advisor, and we're here to have a conversation around excessive bleeding after birth. And the reason why we're having this conversation is because excessive bleeding after birth, that is PPH, is the leading cause of maternal deaths globally. So we lose 70,000 mothers every year, which is very unfortunate. And almost 90% of these deaths occur in Africa and Southeast Asia. So this is an issue that has been addressed in high-income countries, but unfortunately, in this region, it's still the leading cause of maternal deaths. The other reason why we're having this conversation is because we have an issue with quality of medicines. And I'm glad that the previous session talked about pharmacovigilance. So some studies have shown, actually a systematic review published by Toloni 2020, that out of a survey, studies that were conducted in almost 40 countries, 40% of the oxytocin that is being used does not meet quality standards. Those are very serious statistics. 40% also of misoprostol and 75% of vigometrin. Please go look out that systematic review by Toloni 2020, a very serious issue. So the other element is that the same results have also been collaborated well under the emotive trial, which was done in Kenya, again, done in 4 countries, Kenya, Tanzania, South Africa, and Nigeria, that showed us that out of, for example, 14 tranexamic acid samples that were taken, only 10 met the quality standards. Out of 17 oxytocins, only 6. So we have a serious issue with quality of medicines, and that is why this conversation is important. So the third reason why you're having this conversation is because there are several innovations that have come up in the PPH space. So the first one is the 2018 recommendation that each stable carbetocin can be used for PPH prevention. In 2023, December last year, WHO came out and said that we have an emotive bundle that can help us address the issue. We're also missing 50% of the PPH cases. That is data from Champion trial and the emotive trial. So to have this conversation, we have a team that is helping us engage. From my far left or right, we have Kibonge, who is a market shipping officer from Perth. We have Atieno Jelango from Fairing Seabirth Project. She's the Africa program coordinator. We have Dr. Chomba, who is the acting director of health product and technologies from Makueni County, who will be sharing with us some early learnings because Makueni County has had an opportunity to introduce some of these innovations. And finally, we have Jacqueline Mainye, who is the sales manager at KEMSA, and she'll be telling us about the availability of this product. So at this point, I'd like to invite Atieno Jelango to share with us some of the key differences between carbetocin and oxytocin and other products.
Thank you very much, Michael, for that introduction, and also thank you to our esteemed partners that are helping us fulfill our vision as a company and as Project Family Safe Birth. Next slide. So at Project Family Safe Birth, we are committed to the women of low and lower middle income countries to ensure that by 2030 we have saved 20 million women from dying due to PPH. And how are we going to do this as a company? By ensuring that we provide heat-stable carbetocin, quality assured uterotonic. So we are responsible for regulatory approvals. We are responsible for ensuring sustainability in terms of offering it at a sustainable price with no end date. And then lastly, we also embody the process of ensuring we introduce it in a safe and responsible manner. And to do this, we realize the job is more than we can take on our own, and that is why the partners are important. So next slide. So the champion trial is the basis of what we now have as Project Family. It was a tri-party agreement between the WHO, MSD for mothers and fairing, each with a specific role, WHO offering more around governance and actually leading the trial, MSD, the technical support and financing, and fairing producing the medication. Next slide. So as we go to the rollout in Kenya, we are now concerned about ensuring safe use of heat-stable carbetocin. Next slide. So key as we speak is just being able to realize that heat-stable carbetocin will be referred to as carbetocin fairing. It comes in ampules and is manufactured for the public sector in China and India to the same specification as Pabal, which is the commercial product. So what we have here is a differentiation, okay? And the other thing that is, apart from the packaging and the different ampules, is the pricing. For the public sector, KEMSA will let you know the price. They are the authority there. But you know already that Pabal comes in at around 11,600 to about 13,600 per pack of 5. Vis-a-vis carbetocin fairing, which will be in packs of 10. Next slide. So carbetocin fairing is the only heat-stable form of carbetocin that is available. Heat-stable carbetocin maintains its potency for more than 48 months at 30 degrees centigrade, for at least 6 months, at 40 degrees centigrade and 75% relative humidity, and 3 months at 50% and about 1 month at 60 degrees. The other forms of carbetocin or oxytocin, remember you must maintain the cold chain. Next slide. So the features of this, it's in an ampule. The label is orangish, and this distinguishes from other uterotonics. Next slide. Critical: carbetocin cannot be used to induce labor, okay? So we don't want it used during pregnancy or labor before the delivery of the infant. Then we don't use it for induction or augmentation of labor. And women with serious cardiovascular disease, women with epilepsy, women with hepatic or renal disorders. And if women are hypersensitive to carbetocin or oxytocin, remember you cannot use heat-stable carbetocin. So in summary, last slide, carbetocin is different from oxytocin. It should only be used after the baby is born or after the last baby is born if it's a multiple pregnancy, with the aim to prevent PPH. It is not indicated for treatment right now. It is not indicated for induction or augmentation. It is the heat-stable formulation of carbetocin, that's carbetocin fairing. It maintains high potency for a minimum of 48 months at 30 degrees and 75% relative humidity. And compared with oxytocin, it has a longer duration of action, very powerful contractions, and which is beneficial for use in PPH prevention, but dangerous for use during pregnancy. With that, I will hand over.
Yeah, so thank you very much, Ati, for that. So we are advocating for prevention and management of PPH across the continuum of care. So we need to do a good job in preconception care, intrapartum care, and also postpartum care. So Makueni County has had an opportunity to test that in several facilities. So I want to invite Dr. Chomba to share with us some of the experiences that we are seeing in Makueni County.
Thank you, Michael. Good morning, colleagues and everyone. So I'm here to share the Makueni experience, not only on the use of heat-stable carbetocin, but also the WHO recommendations on PPH management. Next slide. So we have several WHO recommendations. There is the use of tranexamic acid. Next slide. The use of tranexamic acid within 3 hours of PPH. There is a recommendation of use of heat-stable carbetocin for prevention of PPH. We have the advanced distribution of misoprostol to mothers who are likely to deliver at home, where they use the misoprostol to prevent PPH, and a recent recommendation on the assessment of PPH, the blood loss after delivery. Currently in our labor wards, we use what we call matchometer, where the midwife just estimates the blood loss. There are new technologies coming in to help us accurately measure blood loss, and also the use of the PPH treatment bundle. Next slide. So through the JHPIEGO, we have a project in Makueni where they have provided the heat-stable carbetocin. They have donated also the tranexamic acid and misoprostol for the WHO PPH management recommendations, where we are trying to see the adoption of this recommendation in our facilities. We are currently using them in 36 of our facilities in Makueni County. These 36 facilities represent over 90% of our deliveries. And the project is in 6 target countries, and also some other 14 exchange countries all over the globe. Next slide. So here is a picture of our governor receiving his stable carbetocin for use in Makueni County. We've been able to use the heat-stable carbetocin beginning January of this year in the 36 facilities. We've trained our healthcare workers on the motive bundle, which is uterine massage, use of oxytocic agents, tranexamic acid, IV fluids, and escalation of care where needed. And through the project, we have a 3-year donation for the drugs. And we also conducted a price and availability survey before we commenced the project in Makueni. Next slide. So early experiences from the project. The healthcare workers are confident in using the heat-stable carbetocin. Atieno mentioned that heat-stable carbetocin is for prevention of PPH. You should not use it for augmentation of labor. You should not use it for treatment of PPH. So carbetocin is not coming in to replace oxytocin. That is key, and through the trainings to healthcare workers are now confident to use the heat-stable carbetocin. What we've observed in our labor wards, there's no more blood spilling all over. The casuals or the cleaners have actually nicknamed the heat-stable carbetocin Kausha, because they have seen that the blood loss is minimal since we started the project in January. The bundle has also helped us to reduce maternal mortalities as a whole, in addition to the heat-stable carbetocin. When the project started in 2022, we had 12 maternal mortalities attributable to PPH. Since the project in 2023 and in 2024, we've not had a maternal mortality attributable to PPH. And I mentioned this, it's not only the carbetocin that has attributed to this, but the bundle approach and the trainees that have gone into the project. And our governor has now been appointed a national champion for PPH to try help us as a country champion the implementation of the WHO recommendations in the country, in other counties, to help us bring down the maternal mortality ratio. Next slide. So another thing is the blood need for PPH. We've seen a reduction in the blood transfusions in the maternities attributable to PPH or hemorrhage in the hospitals. Thank you.
Yes, so thank you very much, Dr. Chomba. So the question is, Makueni County has had this great experience. So how about the other counties? So there are efforts at the national level to make sure that some of these innovations and products are available, not only in Makueni as a donation, but to all counties. And we have our colleague from KEMSA. I will come and share the progress towards national availability of these products and technologies within Kenya.
Thank you. Thank you, Michael. Good morning, everyone. My name is Jacqueline Mainye. I'm Sales and Marketing Manager at KEMSA. Next slide, please. So KEMSA is coming in as the national procuring entity. And just a brief, the MOH Division of Reproductive and Maternal Health in cooperation with partners in maternal health, developed a national quantification of PPH Commodities Report 2023. And this is a significant step towards addressing Kenya's persistent problem of high mortality. Oxytocin and misoprostol are currently being used for PPH prevention. We also are stocking at KEMSA tranexamic acid. Heat-stable carbetocin has been introduced for PPH prevention, and MOH has predicted that the level of use for carbetocin injection will be at 60% and 40% oxytocin across all levels. Heat-stable carbetocin will be used for prevention of PPH in both vaginal and C-section deliveries in line with national guidelines. Next slide, please. Yes, so now KEMSA comes in specifically on heat-stable carbetocin. There is a revision on the level of use of heat-stable carbetocin in the new Kenya Essential Medicines List 2023. It will now be available from level 2 upwards. Previously, it was only available from level 4. In the initial procurement quantity that KEMSA is undertaking, the baseline is obviously from the current utilization of oxytocin. At the moment, we have a monthly projection of around 210,000 ampules of oxytocin. And with the predicted level of utilization of 60%, we've also done our quantification, and we have an annual projection, initial annual projection of 360,000 ampules for heat-stable carbetocin. The product will be available from KEMSA. The current commercial price for heat-stable carbetocin is from Kenya shillings 2,700, and we stocked this product before at KEMSA. But now we are transitioning to the access product, which will be available at a unit price of 95 Kenya shillings. Next slide, please. So KEMSA initiated, this is our journey towards availing this product at KEMSA. We initiated this procurement in September last year, in line with the public procurement law. We have gone through all the stages and up to contracting, and we have actually issued the purchase orders for the 360,000 ampules to the supplier. The delivery lead time is around 12 weeks, and I am happy to confirm today that this product will be available at KEMSA by latest the 31st of July 2024. Next slide, please. So how are patients going to access or benefit from the price? As I said, the price will be at 95 Kenya shillings. Our ordering tools and our LMIS ordering platform have already been updated. For those of us who are accessing the KEMSA ordering platform, you will see the price has already been updated to 95 Kenya shillings. And the patients are going to benefit from the price of less than $1 per dose. $1 will be around 130 Kenya shillings. So depending on the charges, the patients are going to benefit from the less than $1 price per dose. Of course, we're expecting the consumption to increase, and we will be monitoring to ensure that we respond proactively to the increase in consumption, and therefore restocking will be demand-based, and the delivery will be to the last mile. As you're aware, KEMSA delivers to the last mile to all the public health facilities in the country. Next slide. Finally, of course, we will continue to ensure that we maintain quality assurance throughout the supply chain process, starting from the procurement, stringent procurement process, to the storage conditions in our warehouses, as well as our distribution centers in the regions, and as well as the transportation vehicles that are used to transport the commodities. We are obliging or in compliance to inspections and regular audits. We are very much in line with ensuring that we have traceability and monitoring of the product. So we have a robust batch traceability system in place to track the product throughout the supply chain. And finally, we continue to do post-market surveillance. We have a robust QA team at KEMSA that continues to do post-market surveillance. Thank you.
Yes, so thank you very much. That was our message for today.